So let's talk about my first talk, and I'm gonna start. And I try to keep it fun. This might be basic for many of you, but hopefully you will get some extra points out of it. All right. So the GI tract, right? It's a lumen that goes, as the talk says, all the way from the gum to bum. So mouth, pharynx, and then the swallowing pipe, your esophagus, and then it connects to the stomach, and then small bowel, which is 20 feet, and then 4 feet of large bowel, and then connects to the anal canal and the anus, right? So that's the lumen, right? And then there are some sort of supporting team here as well. There's salivary glands that produce saliva, and then there is liver, there's gallbladder, there's pancreas, and these organs also support what your GI tract does. So all together we call this digestive disease system. So it's a very complex system, and it's a huge organ. I mean, depending on what Wikipedia page you look at, the biggest organ is skin, and the gut becomes the second biggest organ, if you want to call it an organ, in our body, which makes it very complicated to study, and each segment does what it's supposed to do. But generally speaking, if we want to summarize it and make it simple, what does it do? It does digestion. It digests your food, which we'll go a little bit more into detail. And as we will hear the talks, it harbors gut microbiome. And this is one field that we did not pay attention much in a GI tract, and now it's becoming a big thing to a point that we think a lot of our body function is controlled by gut microbiome. And also detoxifying the toxins that enter in our body, especially through the liver. So whenever you eat, whatever thing that gets absorbed gets through the bloodstream. But that bloodstream, in majority of the gut, goes through the first pass through the liver. And liver essentially filters this, allows some things to go through, detoxifies and gets rid of some of the toxins and pass it through. And that's what we call first pass, and that's why liver is very sensitive to some of the toxin that we take, because it's the first line of defense when it comes after absorption of a toxin. On the other side, it makes sometimes things tricky, right? Some of the medications that we take, liver takes it, neutralizes it, and then it's gone, right? So that's why we have to take some of the medications through intravenous route, right? So we can't take it orally. So it's a very complex system to deal with. And then the immune system. Gut is actually the second biggest immune organ in our body, and that is very important because it helps us with fighting infections, fighting autoimmune disorders, and also it might turn on us and causing autoimmune disorders itself. So now we have gut-directed immune therapies that are helping us fighting some of the diseases that are involved in the gut. But now the cool thing is that these four functions are intertwined. They work together, right? So digestion, obviously whatever you digest affects the gut microbiome, and the other way around. Gut microbiome affects how you digest things, right? And obviously whatever gut microbiome produces can affect how liver detoxifies things, because those things that bacteria produces, and you're going to hear a lot about it in the next few talks, they can get into the liver and affect the liver as well. And then the immune system. The gut microbiome activates the immune system in the gut, and vice versa. And also what we eat affects the immune system in the gut and also gut microbiome. So all these four things are completely intertwined. All right. So what is digestive process? When we talk about digestive process, essentially, if you had some breakfast, obviously the first part is ingestion, right? Swallowing it and chewing it, and food needs to be propelled throughout the gut. We're going to talk how food gets propelled throughout the gut, but then the mechanical digestion starts. Mechanical digestion is essentially the trituration, the grinding of the food in the stomach and small bowel that breaks down the food. I'm going to have some slides on that as well. And also the chemical and secretaries digestion. Chemical can be with acid, for example, in the stomach that breaks down the compounds, the bile that breaks down the fat, and also the enzymes that chemically digest the food. And then absorption happens, and then eventually what is left needs to be defecated, and we'll get there how it works. So let's talk about a little bit about the basics of your gut. So if you get your gut lumen and you cut it at that point, you'll see generally the same pattern. So at the beginning, there's just the lining of the bowel, where you see here the lining of the mucosa of the bowel, generally one line of cells, and these are very important cells because they're the first point of contact with food and whatever is inside the gut lumen, right? So the junction between these cells are very tight. We call them tight junctions. And the health of these cells are very important because if they're not tight, then bacteria can go through, inflammatory cells then can come out. Something in layman terms we call it leaky gut or increased permeability of the gut. So that's a big problem, and there's lots of research that is going through that. Underneath that lining of the bowel, then there is submucosa, right? Submucosa involves some connective tissue disease, some supporting veins and vessels that bring some blood and also take the nutrients back to our body. And then we'll have the muscles. And these muscles, think of it as a snake. There is some circular muscles, and also there is some longitudinal muscles, right? So, and coordination between those two muscles makes this snake move forward. And the same thing happens throughout the gut, from literally esophagus all the way to the end of the colon, right? And outside of the this section, there is a layer like foil. So it goes around, and we call it serosa, that it wraps the gut, right? So that contains the gut. And a lot of diseases involve that area that affects the motility of the gut as well. So these four layers, the mucosa, submucosa, the muscle layer, and that wrapping around, these four layers, you can see it in majority of the organs. But it's not the same all throughout. This is the picture under microscope that you see in different parts of the gut. So esophagus is pretty flat and bland, and it's a different type of cell. These are squamous cells, similar to what you have on your skin. But then when you get to the stomach, you see how different it is, right? So now these are cells that produce a lot of acid, they produce a lot of enzymes. And then when you get to the small bowel, now you see these finger-like structures that, if you have had tripes, those are the tiny villi that you can see, and those are these villi that you see underneath. And you can see how nicely they're organized, and they are involved in absorbing food and also producing a lot of enzymes, immunity, harboring a lot of microbiome that you will hear about. And then the large intestine essentially flattens out because it's mostly involved in sucking the water out and keeping the stool a little bit on a dry side, and that's what essentially the colon does. So what this tells you is that you can't expect the microbiome of each segment of the gut to be the same because the lining is not the same and their job is not the same. That's why their diseases that affect these parts of the gut are not the same. So let's go a little bit deeper to go piece by piece down. So swallowing. So think about this. Actually, it's a very, very complex phenomenon. There is a lot of stuff going on, right? So there is air going through your nose that constantly goes to the airway, right? And when you're swallowing, you're chewing everything, and then you swallow. So the soft palate blocks this area, so the air can't go through. If you haven't tried, if you're swallowing, if you want to breathe at that point, it's impossible, right? So it's you can't do it because soft palate blocks it. And then obviously the airway also gets blocked and the food goes down. So there is like multiple ways here, and each swallowing multiple nerves have to work together for this phenomenon to happen. So let me show you actually one of the first videos that was ever recorded of swallowing. This video is almost 70 years old. You can tell, huh? Alrighty. So that's the swallowing. So obviously, we don't use this amount of radiation these days, but hey, these are the days that they used to check your shoe size with radiation, if you didn't know that. There was X-ray machines in shoe shops to check your shoe size. But anyhow, so you can see how nicely the bolus is going through the swallowing pipe, and it's a very complex phenomenon. But diseases that affects the muscles in the throat, stroke, autoimmune disorders, and multiple other diseases affect this part, and swallowing becomes affected. So that's why we have a whole field of swallowing disorders in medicine. Alrighty, so how does esophagus pushes things forward? Remember that snake using the muscles, right? There is this circular muscles, and then there is a bolus on top, and it pushes things forward, right? So it's dumps things down. So there's some diseases that this phenomenon is gone. So achalasia, right? Esophagus does not move, so you're dependent on the gravity and lubrication of the esophagus for food to slowly just descend into your swallowing pipe to help you digest food. And obviously, the hallmark of those diseases when esophagus is not working is swallowing difficulty, or we call it dysphagia, that we see in those diseases. How do we measure it? I brought some gadgets for you that you can go and see, but we use a manometry. It's a catheter that goes through the nose. It has multiple sensors throughout it, and we can measure the pressure. It also has impedance sensors, so if liquid is going around it, it can tell you how the fluid is going through. So this is me when I didn't have beard. I still didn't have much hair, but when you do the manometry, this is how it's done. So you put the catheter in through the esophagus, and this is how it shows up. So on the left side is the pressure index based on millimeter of mercury. So the more red or magenta it is, the higher the pressure, as you can see here. And the more blue it is, the pressure is low. On the right side is actually the anatomical index. This is the upper esophageal sphincter over here. And this is the lower esophageal sphincter at the bottom here. And this is your stomach. And stomach is full of liquid at this point. So when I'm swallowing, the liquid is going through, and esophagus contracts and pushes things forward. And that's the movement that goes through and dumps in everything into the esophagus. And every segment of this phenomenon can be affected by a different disease, and it can present with different sort of symptoms and needs different type of therapy. How about the stomach? Esophagus enters the stomach, and stomach is a little bit special because it has a third layer of muscle around it. It's called oblique muscles. And what it gives the stomach is that the most complex way of contractions. It can go forward, it can go backward, it can go literally sideways, it can titrate, it can move things up and down, and it can sense how things are moving. And that's why it has been so hard to figure out how the electrical activity of the stomach works, as opposed to different parts of the heart, that we know how exactly they contract and the electrical activity works. So in the stomach, this part, the top part that sits underneath your ribs, is called fundus. And then this part is called the body. And this is the antrum. And then this part that connects to the small bowel is called pyloric channel. Okay. So right now you had your breakfast. Food goes in, depending on how heavy of a food you ate, right? Food goes down, gets pulled into the fundus, and slowly gets fed into the body of the stomach. And the body of the stomach breaks it down, produces a lot of acid, mixes it up, and tries to break it down into almost 1 millimeter pieces. As it makes it to 1 millimeter pieces, it tries to push us towards the small bowel, and pylorus senses it whether it's that small or not. And if it's small, then it gets pushed back into the small bowel. If not, it comes back and continues to titrate and grind the food. And that's happening in all of you and me, because I just had my breakfast, right? So if I eat something light, right, let's say a little bit of a carbohydrate or a very light bread, it's going to take about half an hour to maximum 1 hour. If I eat heavy, including the sausage, and then add some bacon on top, then it's going to take 4 hours for it to empty. So that's why different type of food have different effect on satiety and also gastric emptying, which is very, very important. So that is called actually the feeding phase. And then when the contents of the stomach enter the small bowel, then the fasting phase starts, that we're going to talk about a little bit more, because that affects the microbiome significantly, and that is that will be in the future talks. So this is the same catheter that I showed you, and you can see that the stomach is contracting. It's faint, but that's what's happening. So stomach, just your heart is beating. That's all, but it beats every 20 seconds. 3 times per minute, your stomach is contracting, and that's the basal contractions of your small stomach. And that changes when you're eating, and depending on what you eat, the contraction vigor, all that changes. A few tests that we have to assess this are, for example, the gastric emptying breath test that assesses the emptying of the stomach. There is a radiologic version of this that you can do it in radiology as well, and we watch how much your stomach empties and whether it's slow or too fast. We have new sort of devices called gastric body mapping that's similar to EKG for the heart. It's the EKG for your stomach, and tells you the electrical disturbances of the stomach. And these are the new gadgets that we have to check whether the stomach is functioning well. The classic problem that we have with the stomach is called gastroparesis, which is the delay in emptying of the stomach, and that's the problem that we have. So how about the next part? The next part is a small bowel. Small bowel is actually 20 feet. It's very long, and the surface of it is about a tennis court, because it has those tiny villi, and that helps you digest and also absorb a lot of compounds. So we talked about the villi a little bit and how the structures look like. And this is how it looks like in real life. So we do see when we do the endoscopy, we can go, the basic endoscopy, we go to the stomach and we get to the duodenum, which is the first part of the small bowel. Beyond that, it's hard unless we use something called push enteroscopy, and that goes for another 50 centimeters. But if you want to go deeper, options become very limited. We have double balloon enteroscopy, and also we have the capsule endoscopy that I'm going to show it here. I brought one example of it that you can go take a look, and these are the capsules that we swallow when it goes and takes thousands of pictures, and we watch that video to see any abnormalities. And the pictures look like this. You can see the tiny villi inside. There's some luminal content. That a lot of research that we do is by sucking this luminal content that you see here. And you can see how beautiful and clean is inside the small bowel if it's healthy. It's not like inside the colon that is, well, is full of poop. But this small bowel stays very clean and neat. This is when we look with this scope and very closely to exactly the same villi. You can see that how nicely they're aligned. And also look at all the beautiful vessels that they come in, take all the nutrients and take it back to your body. So they're all sitting there like a shag carpet that are sitting there. So also in the small bowel, there are the pancreas empties there, and also the liver and also bile produce bile acids that they go into the beginning of your small bowel. That's very important. Why? Because the stomach produces a lot of acid, and we'll see how much acid it produces, and that is caustic to the small bowel. So pancreas's job is to neutralize that acidity. The acidity of the stomach is about 2 or to 1.5. That's the acidity that if you have that acid and you put it on a steel table, it's going to go through that within half an hour. So that acidity, if you once go to the small bowel, then it's trouble. So pancreas's job is to neutralize that acidity within 2 inches of that acid entering the small bowel to a perfect 4.5 to 5, which is quite amazing how pancreas does that. On top of that, pancreas produces other enzymes, and also enzymes that go into our blood, the most famous one being insulin. All right. So how much liquid is produced in our body? A lot. So just for you to have an idea, just our stomach produces 0.5 gallon of acid per day, right? And that acid has a pH of 2, and at the crypt it's actually a pH of 1.5. So it's a lot of acid that is being produced per day. So also you have to remember it'll take a lot to take all that acid production away. So stomach is very resilient. Obviously, there is a saliva that is being produced. There is pancreatic secretions, and in total, there is 10 liters of fluid that goes, or 2.5 gallons of fluid that goes through our gut every day. Where does it get absorbed? Almost all of it in the small bowel. So the small bowel is the one that absorbs almost 8 liters of it out of 10. Some of it obviously gets excreted in the feces, and a little bit of it gets absorbed in the colon. So the biggest part of our GI tract that absorbs water is small bowel and not the colon. That's why it's sometimes when you have severe constipation, just drinking extra water is not going to do much because the majority of the water is getting absorbed in your small bowel. It's not going to reach your colon. You're just going to drink a lot of water, and you're going to urinate more rather than the water reaching the colon. So that's very important. Also, we do measure the contractions of the small bowel, and you will see it here in this picture. We call it migrating motor complexes, right? So remember, we talked about the feeding phase of the stomach. After that food enters the small bowel, then you enter the fasting phase. And the fasting phase of the small bowel is like clockwork. And we didn't know about this until almost 30 years ago. Before that, we did not know this. So at the beginning, the small bowel stays silent, and that's for the enzyme to reach that food that is entered the small bowel from the stomach, breaks it down, and then the second phase, which is the longest phase, happens. The second phase is non-propagating contractions of the small bowel that breaks down the food and allows that food to get mixed up with the enzyme, and also getting close to those villi to get absorbed and then finally get the nutrients to you. And then every 2 hours, what I would say, something like this, which is the magic in the small bowel happens, the migrating motor complex phase 3, which is the housekeeper wave. So it starts from the beginning of the small bowel, sweeps all through the small bowel, and dumps everything into your colon, the whole 20 feet. And at each segment of the small bowel, it only lasts about 5 to 8 minutes. Just like when you sweep the floor, it just does a few sweeps and moves forward all throughout the 20 feet. And this is very important because the health of the microbiome is dependent on this. Because if they don't exist, then the microbiome is not going to stay healthy, just like a quagmire versus a stream. So the bacteria will start to grow, and the bacteria from the colon will creep back up into your small bowel that you will hear about it in the small intestinal bacterial overgrowth talk. And these contractions almost happen about 11 to 12 times per minute, and it goes through. So very important. So we're getting to the colon. So now small bowel connects to the colon, and at the beginning of the colon is called cecum, and this is where the appendix connects. Appendix classically is considered a vestigial organ. That's a concept that is being challenged significantly, and we are finding a lot of work that appendix does for you. So one part of it that we know that it's important is the fact that it can harbor a lot of microbiome, especially archaea, that can repopulate the microbiome of the colon when it's wiped out. So it can act as a reservoir to repopulate the microbiome in the colon, which is a fascinating phenomenon. Obviously, when it gets inflamed, the classic disease that is associated with it is appendicitis, that if it's severe, that it needs to come out, although the new data is showing that you can salvage the appendix by antibiotics, but that's a talk for surgeons. So the rest of the colon has an ascending colon, transverse colon, and descending colon sigmoid, and then cecum. This essentially wraps around the whole abdominal cavity. So it's a loop around, as you can see on the picture here. So that's why it's really hard sometimes with the GI disorders to see where the pain is coming from, because these are not small organs. They're all over the place, right? So the colon is all around, the small bowel is all over the place, and also the detection of pain in our bowels is not accurate. It's not somatic. So the pain that you feel somewhere, it might be coming from the other side. So it's not accurate. So that makes us a little bit hard to diagnose where exactly the pain is coming from, and we become dependent on tests to see where the source of problem is. How does inside the colon look like? Let me just run this. Alrighty. So that's inside the colon. You can see the vessels, and that's a little bit of a stool, and you can see the vessels, how nicely they're in the colon, and you can see that as we come out. Well, now I have a surprise for you. That was not actually human. That was actually a mouse. So, but it's amazing how GI tract of mammals look similar when we do colonoscopies or endoscopies on dogs, pigs, and also mice. It's quite similar that we see. And that's a beauty of evolution. And in our lab, we do a lot of colonoscopies, so I thought I'd put that up for you to see how that looks. And then the colon obviously leads to the rectum, then the anal canal. And this is an area that is very busy. Multiple vital organs are there: the perineum, the uterus, the bladder, the prostate, the ovaries. It's a very complex area. And I'm just going to quickly talk about how defecation occurs. So we have, just to familiarize you with the anatomy. So if this is a cut from the side, right? This is the pubic bone, and this is the spine, and this is the tailbone, right? The bladder sits here. Behind it is uterus and rectum. Obviously, in men, this doesn't exist. And the prostate sits over here, okay? So rectum sits behind this, and then there is a sling that connects to the pubic bone, comes and goes around the rectum and goes back to the other side of the pubic bone. But that gives the rectum an angle, something we call rectoanal angle, that gives us continence, and that's very helpful on top of the external anal sphincter over here. So when we have a bowel movement, this relaxes, the rectum straightens, and the anal sphincter voluntarily we relax it, and stool can go out. But you can see that how many things can go wrong if this complex phenomenon does not occur. So, and that's what we call defecatory disorders. It can present themselves as constipation, fecal incontinence, inability to push out, straining, and that's one whole field by itself. So this is our team. Obviously, none of the work in our group can happen without the research team and also the clinical team to collaborate. Interesting enough, I was trying to find a good picture that includes everybody, but unfortunately, during COVID times, we don't do group pictures anymore. So I couldn't include everybody, but I just wanted to see that behind all the things that we do and you're going to hear about, there is like 50 researchers and clinical clinicians that help us push things forward.